Good morning. My name is Nicholas Volpe. I'm from Chicago, and pleased to see all of you here at 8 o'clock in the morning to hear about some guidelines to the practical workup of common neuro-ophthalmic problems. We have some truly superb speakers, and I think you'll find this will be a nice review of some of the basic and more common problems. It's interesting, yesterday we had a session, and it was actually news to me to recognize that in different languages there are different terms, and that separating disc edema from swollen optic nerve from papilledema may not be the same distinction that we all make. So I'll use the general term swollen optic nerve. I think that's the most accurate, since not all of it is disc edema, not all of it is papilledema. I have no relevant financial disclosures. The optician company is a visible light OCT that I will not discuss here. So here's a list of the things that you should think about when people have swollen optic nerves. And many of these things are common, everyday neuro-ophthalmic problems, especially optic neuritis and anterior ischemic optic neuropathy. And of course, papilledema. We won't get to talk about all of these entities, but I think the table on the bottom is actually the more important one, right? Those are the optic neuropathies that can present either with normal or pale optic nerves that were never swollen. I'm going to start with this case, which might be interesting to the guys on the table, but it'll make a very small and significant point that I think you'll find worthwhile. And it's a 74-year-old man that has double vision. Can't drag the whole thing out as it happened, but this was a man who had had disc or back surgery, and over time he noticed that he started developing headaches that were positional and required narcotics. So every time he stood up, he had a terrific headache. Then all of a sudden the headache started getting better and taking on a different characteristic, where it was a more constant, low-grade bifrontal headache, almost worse when he lied down, with some double vision. He had tinnitus, but not jaw claudication. Remember, that's an important symptom for temporal arteritis. And his back pain that he had the surgery persists, and he was found to have a pseudomeningocele, which was a collection of fluid around his back surgery. Good vision, very important distinction in patients with swollen optic nerves. Normal color vision, no afferent pupillary defect, a little bit of anisotropia, full visual fields, and these were his fundi. So we were confronted with swollen optic nerves in an older patient with good vision, and this is a rare instance, and I don't know if everybody would agree, but I actually thought that the differential diagnosis included both papilledema and giant cell arteritis, mostly because of all the cotton wool spots that were associated with the disc swelling. And in my opinion, the fluorescein angiogram was the perfect test to sort through these two types of disc swelling, because fluorescein, remember, is great for looking for choroidal perfusion defects for temporal arteritis, and of course it demonstrates typical late staining and leakage here in patients with papilledema. So he had no choroidal defects, and we postulated that he had first a low pressure syndrome, then proteinaceous material leaking into his spinal fluid, giving him a high pressure syndrome. We treated him with time and Diamox, and his disc swelling resolved. So let's talk about papilledema. This is the most important and easy to recognize acute disc swelling. Key, most and all patients, unless it's end stage, have pretty good vision and minimal visual symptoms. The classic symptom that goes with papilledema, of course, transient obscurations, typical elevation and hemorrhages, cotton wool spots when it's acute. We talk about early obliteration of the cup, dilated capillaries on the surface, and hyperemia. The absence of spontaneous venous pulsations, which we now can look for pretty easily with a little OCT video. And this would generally indicate that the patient has low pressure in their spinal fluid. Remember that dead axons like these don't swell. There is undoubtedly a disease that presents with headaches. That's IIH without papilledema, but not at risk for vision loss. And I always thought it was interesting to make the observation that just a little bit of sheath pressure can cause papilledema, as opposed to it almost never causing a vein occlusion type picture. As it becomes chronic, you evolve into the champagne cork, the classic Patton's lines, shunt or collateral vessels, exudates in the macula, all typical. Papilledema develops, of course, because of pressure in the sheath, causing axoplasmic stasis. The sheath, as seen here in a patient who autoenucleated himself, you can see has sort of a rubbery quality to it, so it's minimally stretching. And what we're seeing here is lateral displacement of Brooks membrane, which will become important when I show some OCT findings. Classic MRI findings: vertical tortuosity of the nerve, empty sella, flattening of the globe. We can sometimes see a little papillae. And remember, we now always do venous studies of the brain to rule out cerebral venous sinus thrombosis in the differential diagnosis. Remember, in addition to optic atrophy, patients are at risk for vision loss from choroidal neovascularization, exudates, choroidal folds, and of course, a fair prevalence of functional or non-organic vision loss in our IH patients. I think papilledema has helped us in the differential diagnosis of disc swelling. Here are some classic examples. Nobody needs an OCT to call this papilledema, but the IHTT study that we did medical treatment of pseudotumor demonstrated on OCT that this forward bowing, if you will, of Bruch's membrane, as seen in this case, and you'll see some distinctions in a moment, is very typical of papilledema. And what we're really seeing there is the flattening of the back of the eye as occurs on MRI scan or other studies. And here's some other examples, again, of papilledema with a slight upward bend in Bruch's membrane, indicating the high pressure. This was demonstrated. Here's some nice examples from the IHTT study showing that once the patient presents, again, bowing up, untreated, successfully treated, reestablishment of the normal curvature of the back of the eye. So here's our papilledema example in the middle, and here are some examples of discs that some experts, maybe not the gentleman to my right, would think are ambiguous, and in this case, the OCT was helpful in indicating that it wasn't bowed forward. So sometimes pseudopapilledema is pretty easy. Ultrasound with hyperreflectivity, fluorescein without leakage or staining, but other times it can be a little bit trickier. These patients are all pretty straightforward: myelinated nerve fiber, drusen, kind of a congenitally small optic nerve, not a difficult group to sort through. Here's some more again, drusen again. But how about these pictures on the bottom here? You know, these are good examples of in my collection of discs that I ended up thinking were ambiguous and I couldn't sort through when I first saw them. In fact, each of those are papilledema, with the best indication that these other pictures shown on top now have shown a significant change, indicating an evolution in consistence with papilledema. Pseudopapilledema would rarely change in between examinations. Modern digital imaging has given us an advantage of being able to be able to align our pictures electronically. So I find it very helpful to be able to use the superimpositions that you can do with the digital archive pictures, and you can just show pretty subtle changes, again, that are pretty obvious when you hold them up next to each other, but when you superimpose them, it gives you this nice advantage of comparing two discs at two different times. So there's a lot of discussion of OCT in the diagnosis of particularly optic disc drusen. With all due respect, this paper was wrong. And then this paper, which was written by a consortium of neuro-ophthalmologists from around the world, is actually the best resource if anyone's interested in how and when to use OCT in the identification of drusen. It turns out that this foam or this peripapillary hyperreflective mass is actually just kind of the scrolled up or pushed aside axons that would be present in both papilledema and drusen. In this study, I won't go through all these pictures, but it carefully demonstrated that in both papilledema and drusen, you can get these little peripapillary masses, and that the best and most consistent findings are to look for these hyporeflective mass lesions with shadowing in the nerve head. And you can do this pretty reliably in patients with drusen. And never forget the importance of going back to fluorescein and demonstrating true leakage as an indication of edema, as patients can develop both edema and in the setting of drusen. Very important, just use history. I know there are patients who are asymptomatic without drusen, but here's results from the IHTT, and you can see that there is such a high prevalence of symptoms if you ask carefully in identification of papilledema. Like papilledema, this patient who presented with 3 months of progressive visual symptoms and gaze-evoked amaurosis, maybe some blind spot enlargement, early inferior visual field loss, choroidal folds a little bit unusual early in the presentation, and of course this is the disc swelling of optic nerve sheath meningioma, which looks almost indistinguishable from papilledema. These are the 4 most swollen optic nerves I've ever seen with idiopathic optic neuritis, and the point being that it's never very swollen, it never hemorrhages, it's a simple disc elevation with blurred margins, no cotton wool spots, and these are typical appearances of optic neuritis swelling. The swelling is very bland. It's still a very interesting thought process to know why only 30 to 35% are swollen. Remember, in our brain, we see white matter lesions in patients with multiple sclerosis, which are these perivascular lymphocytic infiltrates. And that's probably what you're seeing in the optic nerve here, but I don't think that's what you're seeing in the optic nerve head, where you're just probably seeing some more inspissated axons that can't get their garbage, if you will, through this infiltrative lesion. Remember that very swollen optic nerves in the ONTT turned out probably not to be optic neuritis in that situation. Some important points about the swollen disc and optic neuritis is trying not to make the diagnosis of optic neuritis if you're not sure. So think twice in patients over 50 and under 15. If the patient just has blurry vision, most young people with optic neuritis can very eloquently describe a scotoma, a darkening of their vision. Small central scotomas, think of macula. Flashing or photopsia, think of retinal diseases like acute macular neuroretinopathy. Remember, most have pain. Bilateral is rare, except in the modern era when we're recognizing more and more patients with neuromyelitis optica. There's no APD and it's unilateral. If it's very swollen, altitudinal swelling, we'll talk about with ischemic optic neuropathy. Any arterial changes, dilation of capillaries, hemorrhages, and exudates, and of course, if the macula is not normal. Almost every patient with optic neuritis will have a color vision abnormality. Every patient will have a contrast abnormality. And the visual fields are generally not ambiguous like this one on the bottom left, which is functional vision loss or a cloverleaf. These are blind spot enlargement and a strict altitudinal defect, much more common with ischemic optic neuropathy. Obviously, it's not optic neuritis if you've got an orbital or optic nerve tumor. The optic nerve does not enhance acutely, so a really good gadolinium-enhanced, fat-saturated orbital study in acute optic neuritis will almost always show enhancement. If only the sheath enhances, then we think of perineuritis. Of course, syphilis, obviously if the LP is abnormal. Obviously, if you're a good electrophysiologist, I put this in there for Gordon, can obviously get corroborating diagnoses on electrophysiology. This is probably the most important point I'd like to make about optic neuritis. Every patient has a confined period of time where they get worse, and then every patient, by sometime in the third week, is at least a little better. They may not be all better, but they've turned the corner. If they're getting worse, then workup is indicated. Atypical cases are bilateral and severe, where you think about NMO and anti-MOG, and those have to be pursued differently. Most evidence, remember, favors early intervention, but only if you get the diagnosis right. And I think we can do our patients a disservice by overdiagnosing optic neuritis in the wrong situations. So here are some other examples of inflammatory infectious optic neuropathies. So perineuritis, bilateral, it's much more like orbital pseudotumor. It's not demyelination, the sheath enhances, and it's treated with steroids. Neuroretinitis, of course, when you see lipid exudates in the macula, we know that this is likely Bartonella or cat scratch disease. Sarcoid, syphilis, particularly if you see choroidal findings. Again, these discs don't look like those discs from optic neuritis. Leber's disease, which occasionally can be associated with hemorrhage, kind of a full appearance. Remember, no staining on the fluorescein angiogram, and again, these patients, at least initially, can be difficult to distinguish from optic neuritis. We talked a lot yesterday about these entities, which are probably on the spectrum of non-ischemic vein occlusion for papillophlebitis, and in young insulin-dependent diabetics, this mild form of ischemic optic neuropathy we call diabetic papillopathy. And to conclude, we'll talk a little bit about ischemic optic neuropathy. Again, very classic appearance of the disc swelling most of the time. Once again, here, if you look at this acute picture in the top left, the whole disc is swollen. As the process evolves, you can see the bottom half of the disc is becoming pale. So this is not an actual true infarction of the optic nerve head, but probably axoplasmic stasis for an infarction that's somewhere in the bottom half of the nerve causing a superior altitudinal defect. But you can see the whole nerve is swollen, even though it's not going to be a diffuse visual field defect. Other typical findings, luxury perfusion, hemorrhages, dilated capillaries, perivascular attenuation. This is a very typical, usually easy to recognize disc appearance in middle-aged and older people. Sectoral swelling favors ischemic optic neuropathy as well. Remember these unusual forms of disc swelling that exist as a premonitory event. Here's a patient that if you follow the pictures, they evolve, and actually she has disc swelling before she has any symptoms, which is one of the peculiar features of ischemic optic neuropathy that can be associated with this change before the patient actually develops vision loss. Remember, these patients generally do not develop recurrences of the disease, and this appearance of an altitudinal pallor to the optic nerve is almost a sine qua non of anterior ischemic optic neuropathy. not to be confused with these pictures, which is the classic appearance of chalky white disc swelling. This is likely a true infarction of the optic nerve head, deprived of blood flow because of posterior ciliary artery occlusions, and all typical of giant cell arteritis. Most of these patients will have other symptoms, not all, so any acutely swollen optic nerve in an elderly patient gets a workup for giant cell arteritis. So, in the end, disc edema takes on many forms. This is sort of the object of all of our obsessions in terms of how we look at patients and what we think about. Evaluate in the context of history. If you don't have vision loss, then you probably have papilledema, perineuritis maybe, but actually the presence of vision loss is very important, as well as the other historical functions. OCT and history, I think, are the two best tools for distinguishing papilledema and pseudopapilledema. Not every person with disc elevation and vague symptoms has optic neuritis. Be careful about making that diagnosis, and always consider giant cell arteritis. Thank you. Okay. So next to the podium will be Jonathan Trob from the University of Michigan, and we're going to hear about Anisocoria.
Good morning, everyone. So anisocoria should be defined as a difference in the size of the pupils in dim illumination. It does not make sense to talk about anisocoria when you're examining the pupils with bright illumination. That gets into another problem. You know this is a very common problem that frightens everyone, patients, nurses, emergency room doctors, and anyone else who's involved in healthcare. So it's fitting that we spend a little bit of time on it and that we all are prepared to deal with this problem, because most of the time it really isn't anything very important. But you need to have a rather quick and simple way of making a disposition, and let me see if I can convince you of one that works. The reason that we spend some time on this subject is because behind the anisocoria there are sometimes important, dangerous lesions. And the one I show you on your left is an aneurysm. Obviously, you would not see aneurysm unless there were more than just a pupil abnormality. The second one, the one in the middle, is a dissection of the carotid artery. Once again, you would say there wouldn't be something like this unless you saw more, but you might be surprised about that. And the third, the one on your right, is a tumor in the chest, and certainly that could be announced just with anisocoria, so we do have to deal with it. So I will propose to you that you ask two questions whenever you see a patient that you think has anisocoria. First, do the pupils constrict normally to light? That is, do both pupils constrict normally to light? And number two, is the anisocoria the only pertinent abnormality? That is, we will call it isolated anisocoria. That makes a big difference in how you are going to approach the problem. And let me give you what many of us like to do and others hate, which would be a flow chart or an algorithm or a diagnostic decision tree. And I propose that you look first at whether the pupils constrict normally to light, and then make a division. Go to the right or go to the left. If you go to your left, the answer would be that the pupils do constrict normally to light, and then we have to our great help a topical agent that will help us make the distinction between physiologic anisocoria and Horner syndrome. And this agent is very, very sensitive and highly specific and will work with almost no delay in the time from the onset of the lesion to the time you're examining the patient. If the pupils do not constrict normally to light, then it's your job to make that distinction between isolated and non-isolated anisocoria. If you can then move to the isolated column, you have only 4 entities to deal with. And this will be the place where you will mostly find yourself at home, namely the 4 entities of tonic, pharmacologic, iris pathology, and the Argyll-Robertson pupil. If the problem is not isolated, and depending upon what other findings you make, you will be dealing with a third nerve palsy or a dorsal midbrain syndrome. And clearly that area is the one that you have to be most interested in, apart from the idea of a Horner syndrome. So let's just deal with this pathway first. Let's assume that the pupils constrict normally to the light. You then do the aproclonidine test, and you find that it is negative. At that point, and by the way, it does not matter whether the patient has ptosis because Horner syndrome is known for being very shy. It doesn't have much ptosis and it doesn't have much anisocoria. So once you have concluded that something can be very small, then or a very minimal finding, you know that it can even be absent. So you have to be a bit careful there, and patients who have anisocoria without ptosis deserve at least a consideration of Horner syndrome. Now let's suppose that the aproclonidine test is negative. You will rely on it and make a diagnosis of physiologic anisocoria, which surprisingly, not to you, but to many people, is a very common condition. At some time in their lives, all of us, in our lives, all of us, 1/5 of us in the room will have a difference in size of pupils, which shouldn't be surprising to you because they are regulated by the autonomic nervous system, and why shouldn't there be a little bit of variation? So you see the characteristics there. We are able to make that diagnosis once the aproclonidine test is negative. I'm going to show you a positive aproclonidine test now because if it is positive, you are entitled to make a diagnosis of Horner syndrome, and then you have to proceed with the appropriate diagnostic studies. So what is Horner syndrome? I don't think any of you are unfamiliar with this. You know that the anisocoria is usually less than 2 millimeters. The ptosis is usually less than 2 millimeters. The pupils will constrict normally to light, always. There may be some sweating abnormality. That is not very common for us. There's some iris stromal pigmentation abnormalities in congenital or infant cases. Again, don't rely on that. The aproclonidine test will cause a reversal in the anisocoria. That is, the smaller pupil will become the larger pupil. And as I say, this test is so reliable that it is very useful, except in children under the age of 1, where the use of aproclonidine is verboten because of the possibility of causing cardiopulmonary abnormalities. So don't use it then. Let me just quickly show you here what it looks like to reverse the anisocoria. Here's a patient with, and never mind about the sound, here's somebody with ptosis, noticing that his pupil is a little bit smaller, and you can see that both pupils are constricting, will constrict normally to light.
Yes?
And then after that, I will put the aproclonidine in, and I hope you will see that the pupils will reverse in size. And there you see the formerly small right pupil is now the larger pupil, and in the dark we can see very clearly the reversal. This is a very good test. I recommend it to all of you. Cocaine is passé. We don't use it anymore except in infants. All right, now Horner syndrome can cause lesions in a very long pathway, all the way from the hypothalamus down into through the spinal cord and into the chest and up through the neck and all the way to the eye. And I challenge you to find a more complicated and lengthy pathway in the body that concerns us. There are lesions in all 3 divisions, you might say, of the sympathetic pathway. The lesions within the first part of the pathway, which is in the central nervous system, will never be isolated. There will always be other neurological problems, so you don't even need to think about that if you're talking about isolated anisocoria. When it comes to the second part of the pathway, you can have isolated anisocoria because it stays out of traffic there. And in the third part of the pathway, which begins at the angle of the jaw, you certainly can have an isolated anisocoria. Many people will have other symptoms, but not all. So that's the second part of the pathway, and there's the third part of the pathway, and we do have to consider all 3. Now in children, the most common cause will be birth trauma to the neck, and we will see anisocoria when they are presenting as infants, but they can also, as infants and children, have chest and neck neuroblastoma, which would be the most common tumor in young people, and that evokes a workup that I think you're all familiar with. In adults, it's a bit of a different story. There, yes, you can also have tumors of the neck and the chest, but there in the acute presentation, we are always concerned with a carotid dissection, which means that blood, as you see in the middle picture here, has dissected into the media of the vessel, causing a narrowing of the vessel and a thrombogenic state. The patients are stroke prone, especially within the first 2 weeks, which is why When a Horner syndrome is new, that's when you have the responsibility of making the diagnosis. Once it's old, carotid dissection moves down the list, but you still have the issue of tumors in the second and third part of the pathway. Let's assume now that the pupils do not constrict, or at least one pupil does not constrict normally to light. And that will put you in a different part of the diagnostic tree. Let us assume that the anisocoria is isolated, namely you have done your due diligence on the exam and you don't find anything except a pupil problem. Now you're dealing with 4 possibilities, and those are the only ones you have to deal with. The first one, let me remind you about the parasympathetic pathway. You know that the afferent input for the pupil comes through more or less the same pathway that drives vision. There's a little bit of an exception there, but for the most part we can say that it does. We know that there are these intrinsically photosensitive ganglion cells that make a little bit of a difference here. But the output is very importantly going through the dorsal midrim, or more properly the pretectal region, and then out through the Edinger-Westphal autonomic portion of the third nerve, through its preganglionic portion, and then eventually through its postganglionic portion, which has as its intermediary the ciliary ganglion. And we will look first at a postganglionic lesion. A postganglionic lesion will give rise to a tonic, also known as 80s pupil, and these are very common. I don't doubt that out here in the audience you have all seen at least one. I seem to see them all the time. They often go unnoticed by the patient because they don't really cause problems, and essentially it's a benign condition that you need not generally worry about if the pupil problem is isolated. So tonic pupils look like this. I will try to give you a video of that to show you that the key feature here, one of the 3 key features, is the tonicity, which means that the pupil constricts slowly, if it does at all, and then better to a near stimulus, and then when it's redilating, it will also go very slowly. So you can see that it is this almost anguished, writhing feature of the pupil. The second abnormality here is that typically the defect will be segmental, so that the pupil constriction is not even.
Look way far away.
And I'm trying to show you a very slow redilatation, and these are the 2 features that we generally put most of our reliance on.
Way far away.
Formerly in the past, we would always put dilute pilocarpine in these eyes to check for the 3rd feature, which is denervation supersensitivity. But now we are not doing that so much anymore because we feel we can make the diagnosis on the basis of the first 2 features. The pharmacologic pupil you're all familiar with. We're always being called to the ward where patients are getting some respiratory autonomically active agent and their pupils are dilated, and we intercept them as they are about to go down for their brain imaging because the nurses are so worried that this very sick patient is now having a brain herniation syndrome, whereas actually you can see that this is what is going on. Iris pathology, very common, most often after cataract surgery, after trauma, after uveitis, even congenitally, not something that you want to ignore, but certainly a common cause of anisocoria. This is a problem for me. The Argyll-Robertson pupil, I never see it. Does anybody ever see the Argyll-Robertson pupil? We hear about it all the time. I don't see it. Will somebody stand up if you've ever seen an Argyll-Robertson pupil? You've seen it. And of course in London, they always see these things in London. Anyway, I don't know what the Argyll-Robertson pupil is. There's a lot of literature on it. I wonder if, and I put this in here, I wonder if they are what we call in English the chronic tonic. I like that word. Is it a little old 80s? I don't know. I don't like the pathogenesis of being a dorsal midbrain syndrome. That never pleased me very much because syphilis typically does not attack that region of the brain, whereas it does attack the autonomic ganglia. All right, finally, the non-isolated anisocoria. The non-isolated anisocoria is where our business mostly is. If you have isolated anisocoria, you're not there. If you have non-isolated anisocoria, do you have a third nerve palsy? Third nerve palsy is never going to come with just a pupil abnormality. It does not happen. You heard it here. Doesn't happen, except in the patient who is in extremis on the neurology ward and whose brain is swelling, but who will be also showing you, I'm a neurologist as well, and believe me, you will not just see anisocoria. That patient will be showing you other signs, a hemiparesis or a change in mental status. But other features of a third nerve palsy might be hiding there, so it's your job to find them. And the lesion, I remind you, is in the preganglionic nerve. This is our favorite lesion. Well, maybe not favorite lesion, but a very dangerous one. The third cranial nerve goes very near the junction of the posterior communicating artery with the carotid artery, and a lesion here can be deadly. Finally, the dorsal midbrain syndrome, people tend to forget about it, but anisocoria is part of that. What I will tell you is, and we do know this from a wonderful research work by James Keene in Los Angeles, that basically the pupillary abnormality is not an isolated abnormality here. There will be something else. The dorsal midbrain syndrome is complicated. You know that it can be due to extrinsic and intrinsic lesions, and so you do have to pay some mind to it. I put this up here as a final note because we've been talking about persistent anisocoria, but many of you know, and many of you have seen patients who have episodic anisocoria. They come in and they say, it just happened to me yesterday, and here it is, and it'll be gone tomorrow, and you're going to wonder how much of a workup you need to do on these patients. I would say you don't. I like to leave these patients alone. Obviously, if you are seeing them in the throes, in the middle of one of these things, it's a bit more difficult. But basically, unilateral episodic anisocoria is an autonomic dysregulation, and we don't need to be worried about it. So these are the take-home messages. Number one, if you are seeing anisocoria, and remember it's defined by pupils, different size in pupils, in dim illumination, do they constrict normally to light? A very important, decisive point about this. And two, is the anisocoria an isolated abnormality? If you have answered those two questions, I think you should be able to solve this problem. If the pupils do constrict normally, then is it physiologic or is it Horner syndrome? Use the aproclonidine test, except in infants. If the pupils do not constrict normally, it's a different problem. Then you must ask whether the anisocoria is isolated. If it is, then decide between those four entities, and that shouldn't be too difficult. And finally, pay attention to the idea of a third nerve palsy and a dorsal midbrain syndrome, because you will be helping your patients enormously if you can make that diagnosis. Thank you.
Thank you very much, Misha. Our next speaker from the United Kingdom, Gordon Plant, will talk about guidelines for the practical workup of homonymous hemianopia.
So, after 30 years in neuro-ophthalmology, I've seen hundreds of patients with hemianopia. And I find that for the ophthalmologists, often what they're being asked is a patient who already has a diagnosis of hemianopia. They've been through their stroke workup or whatever, and they're coming to the eye clinic wondering if there's anything that can be done. So I'm going to concentrate on this talk on that situation, a patient coming to you with a diagnosis of hemianopia, and they want to know if there's anything that an eye doctor can do to help them. So the basis of hemianopia, as you all know, is the crossing of the nasal retinal fibers. But it hasn't always been understood that way. And as we're in France, I thought I would celebrate Descartes, who, like all in the 17th century, thought that there was no crossing of the nerves in the chiasm. They thought that the fibers in the optic nerves touched, but there was no crossing. Of course, they didn't know about the rest of the brain, and here's the pineal that was actually analyzing this image. So it was complicated to work out how there was single vision. And then in 1824, Wollaston published his personal experience of two episodes of transient hemianopia in his life. And reading about this taught me two things. It taught me how clinical observation can lead to fundamental changes in our understanding of anatomy and physiology, but also how doctors actually talking about their own diseases can also make discoveries. So what he had noticed, he had two attacks 15 years apart of transient hemianopia. One was on the left, and this second one was on the right. It was only after the second one that he realized how significant, or at least that he was confident enough to publish how significant this was. Because he had lost half of his vision with both eyes, he realized that there must be a hemidecussation of the optic nerves, and that Descartes' scheme was not correct. As it turns out, Newton had already worked this out from first principles more than a century previously, but it was published only as a little footnote to his Optics. And here is his scheme based simply on the solution of the problem of how we see a single image with two eyes. And he produced this absolutely perfect, with no anatomical evidence, representation of the chiasm. This is not his drawing, but it was based on his theory. Newton came to this conclusion because he believed, he had been told that in lateral-eyed animals there was no crossing of the nerves. In fact, there's 100% crossing, but the conclusion nonetheless was correct, that in humans and in forward-eyed animals there has to be a hemidecussation. So here we are, we now understand this. So how can we help patients who come to us? Well, here's an interesting case. I was asked to see some years ago a family with an exotropia and an alternating fixation. And you could set your watch by them. First they'd look at you with one eye, and then they'd look at you with the other eye. A similar family was studied some years later in Holland, and was found to have no chiasm. So this is a case of achiasmia, which was also the case with the patients that I saw. And this, in fact, was discovered by an electrophysiologist, Karl, who was referred one of these patients, and in her report to the ophthalmologist said, this patient has no chiasm. Of course, they didn't believe her, but there was the scan to prove it. So come back, Descartes, all is forgiven. There are some people like this. So what problems does hemianopia cause when the patient has this problem, this clinical syndrome? Well, often nothing. We see many patients who have congenital hemianopia, and they have no symptoms. They don't appreciate that there is anything wrong with their vision. It's what they've always known. I have a patient with a congenital hemianopia who was a county standard badminton player. So adaptation for children, adaptation to hemianopia can be phenomenal, such that there is no disability associated with it. And in this situation, of course, your job is simply to ensure that it is congenital and not due to an acquired lesion, and reassure the patient. In languages where reading is from left to right, right hemianopia is a problem for reading because of inefficient scanning, and we're going to talk about that in more detail. With a left hemianopia, reading is still impaired, but the problem they have is finding the beginning of the next line. Impaired visual search, so this, for example, would give a patient a problem in dealing with a complex scene outdoors. Could be an issue when driving, for example, and finding things on a table. But the patients can adapt to. They can adapt to this task with the hemianopia, but not if they have neglect. So it's very important to know if the patients also have neglect. And from the practical point of view, for many patients, it's the loss of their driving license which is the most serious disability. So it's also important to remember many patients with hemianopia have a unilateral posterior cerebral artery occlusion, and this is actually very rarely associated with other visual deficits. It is generally an isolated hemianopia. With mass lesions, it's a different story, and that was the basis of David Kogan's rule. I don't know if people still talk about Kogan's rule. This was basically that if you see a patient with hemianopia, it's a pre-CT scan concept, that if you saw a patient with a hemianopia and their ipsilateral pursuit was abnormal, which can be tested most easily with the optokinetic drum, then it was more likely to be due to a tumor than to a stroke. And the reason for that was the mass lesion was more likely to involve the white matter and the connections from the parietal lobe down to the brainstem mediating pursuit. But it's important also to remember that in neglect and hemianopia are dissociated. So if you have neglect without hemianopia, that's very disabling. If you have neglect with hemianopia, that's a little bit more disabling. But hemianopia without neglect is much easier to cope with, because the patients are much more likely to adapt to the loss of vision. So there's some basic testing you can do for other visual defects. As I say, abnormal ipsilateral pursuit indicates parietal involvement. Patients with a right hemianopia and a left hemisphere lesion may have an acquired alexia. Now, we have a huge advantage in the English language, which I'm sure non-English speakers curse us for, is our irregular spellings. You don't have this in French, but in English we have many, many irregular spellings. And these are a wonderful quick test for an acquired alexia, because what patients with alexia cannot do is read the word shape. They read letter by letter. So they would read pint as pint, yacht as yacht, bow and whatever the GH they choose, buff or whatever. So this is what we use to test for an acquired alexia, a language problem with reading, with a right homonymous hemianopia. For neglect, you can do the visual extinction test. Just test the patient. If they don't have a hemianopia, you can test them in both visual fields. Isolated unilateral stimulus and bilateral. And when you test bilaterally only, they will miss the target in the affected hemifield. That's testing for unilateral neglect. But if they've already got a hemianopia, you can't do that. So what you can do is just put a load of symbols like this on a piece of paper and ask them to cross out all the zeros, and you'll find that they do not look towards, they do not shift their gaze towards the affected side. So they won't cancel the zeros to the right or to the left, whichever side it is. We've developed a cortical vision screening test, which is available on the web now. We don't have a print version of it anymore, where you can see other tests that are available. So patients will often come to you knowing that there are rehabilitation strategies for hemianopia. These are all on the internet. So if you don't look them up, the patients will look them up. And this is what are known as Peli prisms. This is a prism which is designed to bring an image from the blind field into the sighted field. So here's an illustration here. So this is, I must say, do remember that patients with hemianopia never complain that they walk along the street and only see half of images, half of the world. The brain compensates for this with eye movements and so on. But this is a simulation of a patient with a hemianopia walking down the street. And here we have a person in the blind field here being transferred across to the sighted field, and with adaptation, eventually the patient will actually see the image in the correct place in the blind field. We have found this very difficult to use because it's not well tolerated. There is a publication coming out by Fiona Rowe. She's completed a randomized controlled trial of this, and they also found that it was very difficult for the patients to tolerate. There is a publication coming out on that. Visual restoration therapy on NovaVision is also well publicized on the internet, and this was based on the idea that by repeatedly testing basically perimetry, doing perimetry repeatedly every day, and testing particularly around the borders of a scotoma, that the sighted portion of the field can expand. This was put to a test by the group in Tübingen, and Sabel, who published the original work, was one of the co-workers, using scanning laser ophthalmoscopy, where you can see exactly where on the retina the stimuli are. And they found that if you controlled for this, so controlled for eye movements, then there was no effect. And Jonathan Horton, who's sitting over there, and I wrote some editorials on this, but the technique is still available. And in fact, there is apparently some more recent work by Crystal Huxlin on this same technique. When it comes to reading, we were very interested in the problem that patients with right hemianopia have in reading. If you measure eye movements during reading a line of text, patients will make a series of saccades across the line of text. And these are not random, they are strategic. We tend, in English, we tend to land on long words, not a and the and an and so on. And we also tend to land on the beginnings of words, because the end of words, I-O-N, I-N-G, and so on, tends to be redundant. So this gives rise to a slow, much slower reading in patients with hemianopia, compared to controls. But a little bit of macular sparing gives you a normal result. So it's been found that optokinetic therapy, so this is basically reading a drifting text daily, will improve reading speed over time, will speed up the recovery of reading speed. And we used as a control task this spot the difference task, which is a search task. There you are if you didn't get them. And that does not help reading. More recently, the team in Tübingen have looked at using search tasks like this, and they've confirmed the same thing. If you use a search task, it does improve the patient's visual search, but it doesn't help with reading. So you basically need both of these techniques for rehabilitation. And so, as I say, your patients will find these. I should add that our two strategies are free on the internet. Doesn't apply to some of these others. Please look at these websites yourself. So for a patient with a right hemianopia who's having trouble reading, at the moment, of course, we only have these tests in English. So we really would like some help from our overseas colleagues to develop other language versions of this. But we have, there are these treatment strategies. Probably they work in the early stages because the patients will learn to adapt themselves to the hemianopia. So when the patient comes to you, do check whether or not they have neglect, because if they do, this type of rehabilitation is going to take much longer and is much more difficult. But if they don't have neglect, then you can assure them that you can help them to to improve their eye movement strategies and to be less disabled. The question of whether this allows them to go back to driving is another issue, and that, I'm afraid, is not yet resolved. Thank you for listening.
Thank you very much, Gordon. Our last speaker will be Karl Golni from Cincinnati, United States, who's going to talk about unexplained vision loss.
Good morning, and thanks for the invitation to speak. So I'm going to talk about a topic that neuro-ophthalmologists see very frequently, and I'm sure everyone in the audience sees it at least on occasion. I have no financial disclosures, and my objective is when we're done, you'll be able to outline an approach, my approach, to the patient with unexplained vision loss. And so I actually tell this to my patients who come in with this problem. These are patients who are said to have, quote unquote, normal exams. What we have to do is figure out where the problem is. This problem could be anywhere from the front of your eye to the back of your brain. I don't go into the third topic with the patient, but I say we have to decide, is it the front of the eye, is it the back of the eye, or could it be nerve, brain, higher order processes? And in my mind, I'm thinking, and if it's none of those, could it be non-organic? Maybe the person with a normal eye exam and a problem with their vision is malingering or has some other psychiatric problem. So as a neuro-ophthalmologist, I thought I was done with refractive and media problems. That's not the case. I still see patients who have come to me with unexplained loss of vision, blurry central vision with irregular astigmatism, oil droplet cataracts, these dense central nuclei that don't look very cloudy, but change the refractive error quite a bit. Occult corneal disease like map dot dystrophy is something I see fairly commonly that's not diagnosed previously. And the evaluations are simple, the things that we're taught to do. Pinhole, near vision. I'm surprised how often I see people who are 20/60, 6/18, who have not had a pinhole vision. And even my patients who are scared because they're sitting in the neuro-ophthalmologist's office thinking I might have a tumor or MS can understand that if their vision improves with that pinhole, they probably don't have something that's too terrible. Retinoscopy, corneal topography can be helpful to look for irregular astigmatism. And don't forget your direct ophthalmoscopes. When I go to my residence clinic and I ask for a direct ophthalmoscope, they say, oh, Dr. Golni, you're ancient. We've got this slit lamp biomicroscopy. And I said, I know, that's supposed to cut through the media opacities. I want to look at the red reflex, and I want to look to see what my view is when I'm looking into the fundus. It's still a great way to judge media opacities or irregularities. And then, of course, you could do rigid contact lens over refraction. And then don't forget the neuro-ophthalmologist's secret weapon, color vision. So central vision loss from optic neuropathy typically causes decreased color vision, central vision loss. Color vision is not as much, nearly as affected by refractive problems, media problems, even retinal disease, unless the acuity is pretty bad, 2200, 636, or worse. The Hardy-Rand-Rittler plates are a bit more sensitive than the Ishiharas. I use them more or less interchangeably unless the visual acuity is very good, 6.6 or 6.7.5. I'm going to then preferentially pick the HRR color plates. So summary for refractive and media, these are the easy ones, but they're often missed in my experience. So don't forget our basic sorts of things, including that direct ophthalmoscope, pinhole, and so on. The second area would be retinochoroid. Is it the back of the eye? And I think the history can be helpful. Nick mentioned this tiny central scotoma that doesn't really show up on perimetry. That's usually retinal. The history of metamorphopsia, if they talk about distortion, crooked, things are broken up, that is usually retinal. So these things should raise your suspicion. Should be looking in the back of the eye. And on exam, of course, if it's occult, there should be no or at most a very small relative afferent pupillary defect. Don't forget your Amsler grid and other form of perimetry. And then, of course, there are all sorts of ancillary studies these days. Friends of mine say, gee, we don't need the retina specialist anymore. We order the OCT, the multifocal ERG, and so on. We could do hour-long talks on all of these topics or all day, so I'm not going to mention them, except these days, I think I see a lot less occult retinal disease because of the newer technologies out there to identify these before they get to me. So the third area is optic nerve or visual pathway or higher order problems. And so, of course, as a neuro-ophthalmologist, I have to stress the importance of the relative afferent pupillary defect. If you're seeing patients with unexplained visual loss and delegating the pupil exam to a technician, you probably should not, unless you believe that technician is just as good as you are at detecting relative afferent pupillary defects. Of course, you need a dark room, a bright light, at least one working pupil, and don't forget to have the patient fixate on a distant target so you're fixing their accommodation while you're checking their pupils. And then our secret weapon to detect optic nerve disease, color vision, as I mentioned. And then, of course, we have all sorts of parametric strategies, Goldman fields, automated, different programs we can run, and then even the Amsler grid. So here's just a case, though, to try to get to a point of a different sort of a problem. This is a gentleman who comes in with his wife. He's got a brown paper bag in his hand, and he dumps it on my desk. There's 5 pairs of glasses, and I said, I don't do glasses. I was hoping it was his lunch. And he said, I've got all these glasses, and none of them work. So for the last 6 months, 8 months, I've been going to doctors because I cannot read. That's his chief complaint. And he says, none of these glasses help. So on exam, he is 6'6", 20/20, OU at distance and at near. And with these patients, I usually, after we check the vision with the near card, I scoot over to his family, who's always there, and say, he just read this little line. I can't read that line. Why can't he read? And that's the question. So this fellow has already had automated perimetry, both a 24-2 field and a central field, a 10-2. It's all normal. And so the question is, what do we do here? So I'm sort of asking that rhetorically, but think, what would you do? You've got a guy who can't read. So what I did was said, well, here's a magazine, read. So I gave him the magazine, and I said, read that paragraph. And he started reading, and he read a little bit, made it through the first sentence, stopped, went back to the beginning, started again, jumped a sentence, looked at me with a puzzled look, started again. And so he has a problem that I think is not uncommon, and you will see it if you're thinking about it. And one of their chief complaints is, I can't read. Anyone know what this is, other than neuro-ophthalmologists? So there's one test that we then did after I heard him trying to read, and there we go. I showed him this. So this is an 8.5 by 11-inch laminated sheet from the Boston Diagnostic Aphasia Examination. I had said, what do you see? And he looked at it, and he said, oh, well, I see a woman washing a dish at the sink. And I said, yes. Anything else? No. Nothing else? No. And I pointed with my finger. I pointed over here to the kid with the cookie jar. And I said, what about, oh, he said, oh, yes. He said, oh, the kid's getting the cookies from a cookie jar. Anything else? No. And I pointed, oh, the sink is overflowing. So he is seeing one thing at a time, so-called simultanagnosia. And he has what we call the visual variant of Alzheimer's disease. So this is something you will see in patients. They may be demented, they may not obviously be demented, but as soon as you start talking to the family about a visual processing problem, the family are all shaking, that makes sense. That makes sense, because they know of things that have been happening. They may not have overt dementia. It may be very early, and these visual symptoms in the visual variant are early symptoms, but the most common symptom is reading difficulty. They just don't read anymore. Maybe they don't complain, or they complain, I can't read. Simultanagnosia, spatial disorientation, ocular apraxia, trouble for reaching for things. And then this is one of the few things in the differential of homonymous hemianopia without obvious lesion on the MRI causing them. And so here are fields in a patient, not the same patient, but a different patient from one of my glaucoma specialists who've been following this patient for ocular hypertension and noting no change in the optic disc appearance over time. And the top fields are from 2007, the next set down from 2008, the next set down from 2009. So yearly intervals, and you can see this patient is developing what looks like a partial right homonymous hemianopia. And indeed, in 2008, my glaucoma colleague said, ooh, I better get an MRI, normal. And then in 2009, they said, whoa, I'm not going to get another MRI. I'm going to send him to Neuro-Ophthalmology. And this fellow had the visual variant of Alzheimer's disease. So summary for optic nerve and visual pathways. Did I miss the relative afferent pupillary defect? Did you check it yourself? Because that's, of course, critical in these patients. Is the color vision normal? Did I do the correct visual field? Was it a peripheral field, a central field, and so on? Or is there some sort of diffuse cerebral dysfunction? And then finally, maybe there isn't a real or an organic problem. Maybe this is a non-organic problem. And I prefer the term non-organic to any of these I've listed up here, although malingering certainly is the most common in my practice. I am not a psychiatrist, although I often feel like one. And these are all psychiatric diagnoses. I don't make psychiatric diagnoses. I call it non-organic. So fortunately, for me at least, the most common type of non-organic visual loss I see is moderate or severe unilateral vision loss, which is also the easiest kind to prove that it's non-organic. And I think your goal is not just to be suspicious that it's non-organic, not to think it's but to know it, to prove that this is not real. And there's all sorts of different ways. My technician of 25 years is skeptical. She thinks everybody's faking. She always starts with the 2010 or the 6-3 line and then gradually works her way up. And by the time she gets to 6-6, the patient thinks, oh, maybe this is normal, and they start reading sometimes. There's the DKR, the doctor-killing refraction. Either they die or you die because it takes so long. I don't favor that. Gradual fogging in the phoropter where you gradually put plus lenses, but as soon as the person starts closing one eye, they can figure that out sometimes. Stereopsis for decreased near vision, that might help, but again, I don't think a great test. But the vertical prism test, which I think is by far the best test, and this is a very simple test. If you get one thing from this talk, this will help you in your future eye care. So you measure their best corrected vision. You put up a single Snellen letter on the chart that's a couple lines bigger than the vision in their good eye. So these are people who have one bad eye, one good eye. So you might put up a 6-12 letter if they're 6-6. And then with both eyes open and with their best correction, you say, can you see that A? And the patients who's not usually will say, well, with my good eye, I can see that A, yes. And then you take a 4-prism diopter prism and hold it vertically in front of the good eye. And that's one of the beauties of this. The patient's waiting for you to test their other eye by putting the prism in front. So they're trying to figure out, what am I going to see with that in front of my good eye? So you put it up in front of your good eye, and you simply say, what do you see? So if the patient is organic, if they truly have bad vision in the other eye, they'll see something like this. They'll see a second image that's blurry. They can't see the letter. You've already measured their vision. Or if they're really bad, of course, they wouldn't see a second image or chart at all. But they should see one clear image and one either very blurry image or nothing. However, if they're non-organic, what will they see? 2 images, one above the other. And then the key question is, after they say, I see 2 A's, the key question is, are they about the same clarity? Yes. What did they just tell you? My vision is the same in both eyes, right? So foolproof, and then you take the prism away, and sometimes they say, well, aren't you going to check my other eye? Not today. So the vertical prism test is simple and quick, and if they see 2 letters of the same clarity, you've got them, period. If they see 1 letter, however, and this is the corollary and just as important, if they see 1 letter, now I'm a believer. Even though I think, oh, this is not, I'm a believer. If they see 1 letter, now I really have to look hard for what is happening with that other eye. I thought they were faking. And I've had that happen too, many times. So, summary for unexplained visual loss. Where is the problem? Is it the front of the eye, the back of the eye? Is it nerve, visual pathways, or higher order cortical? Or is it non-organic? Use common tools that you all have. Use them. Get the correct visual field test. Prove it's non-organic. I want to prove it's non-organic before I come up with that as a final pronouncement. Every time I see someone with non-organic vision, I think of my college roommate who was born with bilateral retinoblastoma. In that year, 1960, they enucleated the worst eye with a big tumor load, and they radiate the other eye. And he did very well. So he had good vision until he was about 11 years old, and he began to gradually lose vision in his good eye. And he went to many, many doctors in the United States. His father was an anesthesiologist. He saw the president of the American Academy of Ophthalmology, who said, see a psychiatrist. About a year later, 1972, CAT scans came out, and they found his optic nerve sheath meningioma, and he, at that time, was no light perception in that eye. So whenever I think of non-organic and I'm going to tell the patient, I think of my college roommate and make sure I've proven it, not just that I think it. Thank you for your attention.